Our next speaker is Courtney Harold Van Houtven, PhD, Master's in Science, a professor in the Department of Population Health Science at Duke University. Dr. Van Houtven is a research scientist in health services research and strategy at Durham Veteran Affairs Medical Center. Dr. Van Houtven is a thought leader in long-term care financing, intra-household decision-making, and informal care. Dr. Van Houtven is co-PI on a VA query program project on caregiver skill training, as well as other important national projects. Thank you.
Well, thank you very much for the invitation to be here today. I'm thrilled to talk about how we might better support caregivers to optimize their contribution to the cancer care force. This is a brief outline of my talk today. I'm going to talk shortly about prevalence because we don't have a lot of data on cancer caregivers. The tasks performed talk about some of the stressors and opportunities we have to increase the capacity of caregivers, talk about the negative spillover effects of caregiving in general, and then some policy implications and solutions. Just to get us on the same page, informal care or family caregiving is defined as family members or friends who are typically uncompensated and providing care at home, devoting significant time, energy, and costs caring for an individual with cancer. The prevalence of cancer caregiving is really difficult because of lack of self-identification as a caregiver in many cases, but also because there hasn't been a lot of devotion and resources to understanding this prevalence in national data sets. Real progress was made in 2016 when the National Alliance for Caregiving did a big survey and they gave a new estimate of there being approximately 2.8 million caregivers who reported cancer as the main problem of or illness that the reason that they're giving care. If you think about the complexity going on as you age and people who report multiple conditions, this could be upwards of 6 million caregivers because other trends like in the medical expenditure panel survey report that would be a more, they're doing multiple things. But if cancer caregiving is the primary reason, then it's about 3 million people. And if you go into survivorship, it's even more, right? This increasing survivorship means that caregivers are providing care probably for other conditions or sequelae from the cancer. I want to give some background. These are not the right slides, but we're going to just go on of the caregiving profile. So caregivers are 58% female. Their average age is around 53. About 40% of them have a college degree or higher, and then 64% reported household income of less than $75,000 a year. These caregivers provide care for care recipients who are most often their parents, so it's adult children who are providing the most modal form of caregivers. And then, of course, to spouses and partners, they receive the most intensive care due to that living in the same household typically. And then others are either non-relatives or siblings, things like that. The care recipients are around 70% female. They have age of 65 and older, around 2/3 are older adults, and then around 40% or so live with their caregiver. And I think although there's not a lot of longitudinal data on projections of shortages and surpluses, which I don't think anyone's concerned about, there is a lot of talk about the concern that with smaller families and delaying fertility and geographic mobility and also females working more in the labor force, that there's real concern that caregiving supply won't keep up with demand. And yet so far that hasn't borne out in the data, not in the cancer-specific realm, but nationally in other studies. But it is a big concern and discussion. So the caregiving tasks are, just briefly, we have around 2.5 activities of daily living that caregivers of persons with cancer provide. And that's slightly higher than in caregiving with persons who don't have cancer. And then instrumental activities are around 4.5 instrumental activities of daily living. Again, we know caregivers provide a lot more tasks than just these kinds of custodial or kind of what people call non-technical skills in the home, and yet they are easily measured in the data, and that's why we always highlight them. So they're very busy with physical and instrumental tasks, things like grocery shopping, arranging visits, and also physical care, helping get out of bed, walking, bathing. I want to just point out, I don't go over this very much in the talk, but that the emotional stress of caregiving of persons with cancer is particularly high. And if you think about the intense episodic nature of it, this is probably no surprise to anyone here. This is looking at that same National Alliance for Caregiving survey, and you see that cancer caregivers, 50% of them report being highly stressed compared to non-cancer caregivers, who only a third of them report being highly stressed. So one of the ways to increase caregiver capacity is to really address problems with their stress and strain. Next, I want to move into caregiving capacity and things that I've noticed in working with clinicians and also working in the healthcare system in both the Durham VA and at Duke. And that is that lack of training is very commonly reported. Although we know that health systems have so many resources for family caregivers, that the caregivers don't feel like they're being trained. Over 50% say that they haven't received any training or have had even little training when they're providing highly skilled care. This is particularly notable because 72% of caregivers report that they help with medical and nursing tasks, things like administering injections, tube feeding, catheter and colostomy care, et cetera. There's also a lot of fragmentation. The caregivers enter a highly fragmented healthcare system in the US, and so there's a lot of duplication and missed information, and the caregivers are often not understanding what's happened before and have to help the patient and the healthcare team understand in order to not have more duplication. And complex patients that have multiple providers outside of oncology care is particularly challenging to the patients themselves and also the family caregivers to try to understand how to create some seamlessness out of this fragmented system. Also, caregivers commonly report that they do not feel recognized. Susanna mentioned this, and I think it's a really important theme, that caregivers don't feel that they're valued as a partner by the healthcare team. And we know that they want to be a part of that team, that they have expertise that is unique about goals of care for their loved one, the symptoms management, adherence information, and just small changes that are so subtle that could be very valuable for the team to know. And they also know patient preferences very importantly. So just to back up, since I wanted to provide a conceptual model, the reason we care about caregiver capacity and the reason that we care about negative spillover effects, which are the economic effects, are really because these are the ways that people cannot provide the highest quality caregiving that they possibly could. And that's why I focus on these two things. It's if you can't provide the highest quality of care because you are so taxed, either financially or because of the strain of your role, then you're not providing highest quality of care. So by having interventions that address caregiver capacity and the negative spillover effects, that is the way that I think we could really improve the contribution of family caregivers in the care force for persons with cancer. I think we don't often think about the negative effects that are economic, but these really do either allow one to not provide enough care that they want because they're juggling work and other responsibilities, or they're incredibly stressed about the burden of that financial strain, such that they are worried about it all the time, and it can lead to depression and anxiety and lower quality of care. So next, I want to just talk about three main domains that we collect data on for what are the negative spillovers to caregivers. This has gotten a lot of buzz in the patient realm with financial toxicity and a lot of great documentation from colleagues of mine at Duke and lots of other institutions, but we don't know as much about caregivers and what they're experiencing. We know from recent research that there's lost productivity at work for caregivers of persons with cancer. They have changing hours, or they've quit work, or they've retired early. And I want to point out that you saw the demographics that caregivers are female, and this is thinking about supports for caregivers is compounded by some things we know that females already do. Females tend to retire early before they reach their full retirement age, and if they are often the caregivers, then they're going to retire even earlier. So they have particular risk for having poverty in old age as they assume the caregiving role. So I think it's important to think about in the policy solutions. There's also a lot of heterogeneity in the response. Again, my colleague earlier said that people increase their work on one of her slides, and that's certainly true. I want to highlight some early results from an ongoing study that I'm working on with Dr. Laura Simonoff and Dr. Maria Thompson. This is an R01 that's collecting detailed biweekly information from caregivers who are taking care of patients who have advanced solid tumors. And right now we have about 163 enrolled caregivers. This just shows the heterogeneity and the work response to being a caregiver of a person with cancer, of advanced cancer. To let you know, over the 24 weeks of the study, almost a third of the patients pass away. So it is really looking at advanced cancer in that end-of-life phase. But the caregivers over this time period have, many of them, around a quarter of them have stopped working for pay. Some haven't changed their work at all. Others have started working for pay or are working more hours, potentially to offset some of the financial strain and that need for more resources. And then others have reported around over a quarter reducing their hours of work for pay. So while they're juggling their home duties as a caregiver, they're also adjusting their work behaviors, both to accommodate that, but that has financial implications, of course. In addition, one of the negative spillovers is high out-of-pocket costs. So this data is quite old. This 1,243 estimate comes from the Caregivers study about 10 years ago, in which I worked with colleagues on a caregiver survey supplement. And we estimated that the out-of-pocket costs for caregivers of lung and colorectal cancer patients was around $1,200, and it varied by where you were at stage of diagnosis and also the amount of time you'd been caregiving. But this could certainly, you could put an inflation rate on that and it would be way higher, probably around $2,000 just by that alone over the past 10 years. And then for advanced cancer, again, that ongoing R01, costs also are high and quite varied. I want to just detail on this very busy slide a couple of main points. This just shows ranked by the median amount that caregivers paid out of pocket in this study where a research member goes into the home every 2 weeks and collects both quantitative survey instruments and also looks at a box where the caregivers have put all of their receipts that they have spent on cancer caregiving, and there's kind of an adjudication process to understand what is the amount that's paid every 2 weeks. And over, on average, a 10-week period, this is the ranking of the types of costs by median amount. And what you see is there's a lot of variability. Loans, nursing, babysitting, transportation, insurance, house payments, appointments, prescriptions, groceries, and clothes. But one of the things that struck me in looking at this, and again, this is early days, so I'm showing this preliminary results, we'll have about twice as many caregivers as the study ends, is that some of the rare expenses, those things like nurses and loans and nursing and babysitting, those were the most expensive. So they're not hitting everyone, but they're very expensive when they do. And then things like transportation costs are experienced by about 90% of the caregivers. And those are also do accumulate quite a bit, so that the median amount over a 10-week period was around $260. Overall, just looking at the totals, I know it's very busy, but the median amount over this time period was around $600 that caregivers spent. And if you look at the mean, it's even higher, just under $1,500. So that means that people in the right-hand tail are really experiencing high costs. When the maximum is $26,000 that one caregiver, at least one caregiver experienced. There are also high indirect and direct economic costs over time. So what I mean by that is the total economic burden is quite high. If you value the time that caregivers spend actually providing hands-on care or support seeking care, navigating the healthcare visits, and doing things like that, then you can see that the amount is way higher than those out-of-pocket costs. Again, this is going back to this 10-year-old now Caregivers study where we had estimated, along with colleagues, the total economic burden of caregivers of persons at different phases, both the initial phase, continuing phase, and the terminal phase of the disease. And we find that they vary quite a bit, but around $20,000 for those in the continuing phase. And this is about a year. So that's a lot of economic burden for people, both direct and indirectly through the opportunity cost of their time. Things they could have been doing at work, they were instead taking care of a person. There's huge reward, so I know it's almost a negative story. We know people gain a lot from this, but there are also negative consequences I'm just wanting to highlight to you all. Okay, and this is again from that ongoing R01, and I want to just emphasize here, we ask in those every 2 week surveys what how people feel about the financial situation that they're in. And this gives additional context to those out-of-pocket costs. And what we see is that 55% of the caregivers are really struggling from their own perspective, in their own words. They're either barely getting by financially, they're falling behind, they have serious financial trouble, or they're in serious financial trouble. Additionally, how are they financing some of the things they're spending money on to help pay for the care for the patient? And I should point out, too, that this is a very highly insured population. These are not people that don't have insurance. They're at academic medical centers, both at Temple and at Virginia Commonwealth. So this is a very well-insured patient population, and yet over 50% of the caregivers report using their own savings to help pay for the care for the patient. They also report 32%, or a third of them, took a loan of some kind. And again, we're not following them for a long period of time, so this is over less than 6 months or so that they've reported this retrospectively, actually. So those could be informal loans from family members or friends, or bank loans, or taking out an additional mortgage, or even payday loans. So quite a range of ways people are going into debt to help pay for the care. The potential solutions, going back to increasing caregiver capacity. These are some suggestions I know we can talk about again tomorrow at the end of the day, but I wanted to just throw them out there to get the conversation going. We really need a more efficient longitudinal team-based care that places the person with cancer and the family at the center. Notably for caregivers, we need systematic training where they actually perceive that they were trained. And this needs to happen longitudinally as well. We need to traverse the oncology silo to include other specialties, thinking about the complexity, and it's not just cancer that people are going under, but also managing diabetes, managing other hypertension, managing obesity conditions, that we really need to think about moving a more holistic approach across the system, not just from different phases in treatment. I really liked the way that you described that, but across from cancer to non-cancer care. So that's a huge challenge, I understand. Some solutions to this would be to use a complex care manager to be a liaison to the family member, having virtual huddles. This is done in geriatrics all the time, even if a caregiver can't come in, and the patient to get their perspectives on how things are going. And it's a very efficient way during a team huddle to bring them in to understand their preferences and things going on. I think this is incredibly important, that there needs to be a dual role of the healthcare team. And I know this happens informally, but it needs to happen more, to include the expertise of the caregiver, because they know these preferences, they know symptoms and small changes, but also caregivers may not have the capacity to fulfill their role in a high quality way. So the healthcare team also needs to assess the capacity and understand whether things are going well and what to do if not. We can talk about incentives later, because I think I'm running out of time, but we need to really change the way things are reimbursed in order to have this happen, either through performance measures, alternative payment models where you can pay for encounters with family members, or pay for that in caregiver liaison. And I think really we hypothesize right now that high quality caregiving leads to better patient outcomes, but in order to make this work in a world of bundled payments, we need to show that evidence very clearly, that supporting the caregiver better will improve patient outcomes. How do we address negative spillovers for caregiving? Well, we need to start in the workplace, for one, for those working caregivers who are making adjustments and maybe leaving their job too early. But we also can support them in terms of offering home and community-based services as a standard benefit to help them, at least in the short term, in the post-surgery and post-treatment phase. We have a ridiculously high expectation that family members can provide incredibly complex care, when someone who is actually trained and a medical personnel could do this in the home if they had benefits. Most people can't afford it or are not covered for that in the U.S. healthcare system. We need paid leave, or at least unpaid leave with job guarantees, so that people can manage their tasks. This won't happen. This won't really solve things over a long term. Paid leave is only usually 12 weeks, and only a handful of states have it so far. And unpaid leave is available to everyone, not everyone, with large employers across all of the U.S., but a lot of people can't afford to take that. Social Security contribution programs is a radical idea, but it would be very helpful to help people who leave the labor force early and to provide full-time caregiving over time. We need lifetime cost caps to help both the patient and the caregiver spouse. And then I want to just say there are serious equity concerns that I would like us to discuss in our panel and throughout the 2 days, whereas even though we know that cancer happens more disproportionately to lower income people who are disadvantaged, we're not really addressing our supports to those people in terms of caregiving. People who are doing well are the ones who are able to access services. So we need to really identify policy levers to target scarce resources to those who are least resilient in the face of a cancer diagnosis, especially those family members and friends who pitch in. And of course, there are people who don't have caregivers. Even though wealthier working caregivers pay more out of pocket, they may feel it less, right? So they pay a lot, but they also have a lot in reserve. And they're also able to take paid leave. A lot of struggling caregivers cannot take paid leave to help provide care. They just can't afford the 2/3 income replacement, and unpaid leave, forget it. They can't afford it, or they don't have access to it as gig economy workers or contract workers or just minimum wage workers. Thank you very much. There's some resources here. There's so much out there. I appreciate colleagues sending information. There's also excellent information for caregivers at the VA, which is a healthcare system I work in. And I also want to acknowledge research assistants from Haley James and Kate Miller at Duke and UNC for helping me, and Erin Kent, my amazing colleague, who provided a lot of the background materials. Thank you.